Hey everyone, and welcome back to the deep dive. Today, we're really diving into something incredibly serious: acute myeloid leukemia, or AML.
Right. It's a very aggressive blood cancer.
Exactly. And honestly, when someone gets that diagnosis, the immediate thought is always, okay, what now?
Mhm.
What are the absolute first, most critical steps we need to take?
That's the key question, isn't it? What happens right at the start?
Yeah. So we're going to zero in on one of the sort of cornerstone approaches, the 7+3 chemotherapy protocol.
Yeah, 7+3. Very familiar in the AML
It
world.
seems like it. And it's not just a treatment. It sounds like an incredibly intensive standard induction regimen.
It is, primarily for newly diagnosed AML patients who are physically robust enough to handle quite an aggressive treatment.
Right. So by the end of this deep dive, hopefully you'll understand not just what 7+3 actually means, but also the specific drugs involved, who is and isn't a candidate, the extensive monitoring and supportive care required,
Which is huge.
and what crucial steps come after that initial phase. It's about kind of pulling back the curtain on this complex, life-saving strategy.
Definitely. There's a lot involved.
So, okay, we've established AML is aggressive, and 7+3 is often the frontline attack. But before we get into the really intense reality of the treatment itself, let's just break down the name.
Yeah.
7+3.
Yeah.
It almost sounds like a code, but you said it literally tells you the blueprint. What exactly does that mean?
It's quite literal, actually. It perfectly describes the rhythm of the treatment cycle. So the 7 refers to 7 consecutive days of continuous intravenous infusion of Cytarabine,
Cytarabine. Oh,
often called Ara-C. That's the shorthand.
got it. Ara-C, 7 days continuous.
Correct. And the 3 refers to 3 consecutive days, specifically days 1, 2, and 3 of that cycle of an anthracycline antibiotic.
An antibiotic, like for infections.
Ah, good question. No, in this context, anthracycline antibiotic refers to a class of chemo drugs originally derived from bacteria, but they're powerful DNA-damaging agents. The most common ones you'd hear are Daunorubicin, or sometimes Idarubicin.
Okay, Daunorubicin or Idarubicin, and how are those given?
Those are typically given as an intravenous bolus, like a faster push, or maybe a short infusion over, say, 30 minutes to an hour, not continuously like the Cytarabine.
Okay, that makes sense. 7 days continuous Cytarabine, 3 days faster Daunorubicin. And when you talk about dosages, you mentioned tailoring it earlier. How precise does that get?
Oh, very precise. It has to be. For Cytarabine, the typical dose range is 100 to 200 milligrams per square meter per day.
Per square meter, what does that mean?
Right, so that square meter refers to body surface area, or BSA. It's a calculation using height and weight. It's a way doctors dose chemo more accurately for the individual size, rather than just a flat dose for everyone. We're trying to maximize the effect while managing toxicity.
Okay, so it's tailored.
Very much so. And that Cytarabine is given continuously, like we said, around the clock for those 7 days. For Daunorubicin, the dose is generally 60 to 90 milligrams per square meter per day for those 3 days.
And the immediate goal here is just wipe out the leukemia.
Essentially, yes.
Yeah.
The immediate goal is to induce remission, to kill as many leukemia cells as possible quickly. It's a synergistic attack.
Yeah.
Cytarabine messes with the cancer cell's DNA replication.
Okay.
And the anthracyclines, like Daunorubicin, also damage DNA and create these cell-killing free radicals.
A sort of 1-2 punch.
Exactly. It's a calculated two-cron assault. And, it's remained a standard for decades because it works remarkably well at achieving that crucial initial remission.
Wow. Still, it sounds incredibly, almost shockingly intensive.
It is.
Which brings me back to who can actually tolerate this. Are all AML patients candidates, or is there a very specific profile?
That's a really crucial point. No, definitely not all AML patients are candidates. This intensive treatment is specifically for newly diagnosed AML patients who are relatively fit.
Fit, meaning younger.
Typically, yes. Younger adults, generally under 60 or 65, though sometimes older patients who are exceptionally robust, very fit, might be considered.
But fitness is key.
Absolutely. The other key factor is they must be patients without significant other health problems, or what doctors call comorbidities, or signs of general frailty.
So no major heart problems, lung issues, that sort of thing.
Exactly. Their bodies need to be strong enough to withstand this kind of, chemical assault.
Okay. So if someone doesn't fit that profile, if they have those issues, it's a definite no-go for 7+3.
Correct. Patient safety is paramount. There are clear contraindications.
Like what specifically?
Well, severe cardiac dysfunction is a major one. A weak heart,
Why the heart specifically?
It's mainly because of the anthracyclines, the Daunorubicin or Idarubicin. They have a known risk of cardiotoxicity.
Meaning they can damage the heart muscle.
Yes, they can weaken it.
Yeah.
So if a patient already has significant heart issues, the risk of worsening it with 7+3 is just too high.
Makes sense. What else?
Patients with very poor overall health, we call it poor performance status, meaning they might be largely bedridden or need a lot of help with daily activities. They wouldn't be candidates. Also, people with multiple organ failure, obviously, and critically, anyone with an active, uncontrolled infection.
Right, you wouldn't want to suppress their immune system further.
Precisely. You can't give such powerful immune-suppressing chemo when the body's already fighting a major infection. It could be disastrous.
So that initial assessment, it really sounds like the absolute make-or-break moment for deciding treatment.
It truly is. It sets the entire path forward. It's fundamental.
Okay, so let's say the patient is a candidate. They're deemed fit enough. That critical decision is made. What happens next? What's the run-up to day one of chemo?
Well, the pre-treatment evaluation is the foundation. It has to be incredibly thorough.
Like what kind of tests?
We're talking a complete blood count, CBC, to see all their baseline blood cell levels, detailed kidney and liver function tests, and really importantly, that cardiac evaluation we mentioned, usually an echocardiogram, an ultrasound of the heart, or sometimes an MUGA scan.
An MUGA scan?
Yeah, it's a specialized nuclear medicine scan that's very good at measuring how well the heart's main pumping chamber is working. It gives a precise ejection fraction.
To make absolutely sure the heart can handle the drugs.
Exactly. Then, of course, a bone marrow biopsy is essential, not just to confirm the AML diagnosis, but also to look at the specific genetics and characteristics of the leukemia cells.
Which might influence things later.
Absolutely. And finally, extensive infection screening. Things like checking for past viral infections, hepatitis, HIV, things like that. We need a complete picture before we start.
Wow, that's a lot even before the chemo begins.
It sets the stage. You need that baseline.
Okay, so the stage is set. Treatment starts. Day one, the infusions begin. Given how aggressive 7+3 is, what are you doing during the treatment to manage the fallout?
Right, it's not just about giving the drugs. Proactive management of side effects is critical. And what's fascinating, maybe, is how we anticipate problems. We know they're coming.
Like what? What's the biggest immediate worry?
One major concern right off the bat is tumor lysis syndrome, or TLS.
Tumor lysis? Sounds bad.
It can be. Lysis means breaking apart. When the chemo starts killing lots of cancer cells very quickly, they burst open and release their contents into the bloodstream.
Contents like?
Things like potassium, phosphate, and uric acid. If they flood the system faster than the kidneys can clear them, it can cause serious problems. Kidney damage, heart rhythm issues, seizures.
Yikes. So how do you prevent that?
We're very proactive. Patients get medications like allopurinol or sometimes resveratrol. These drugs help break down the uric acid specifically, and crucially, lots and lots of IV fluids. Aggressive hydration to help flush everything out through the kidneys.
Just constantly flushing the system.
Pretty much. And we monitor blood tests very closely, electrolytes, uric acid, kidney function markers like creatinine, LDH, multiple times a day sometimes, especially at the start.
It sounds like you're fighting a battle on two fronts. The leukemia and the side effects of killing the leukemia.
That's a very good way to put it. And TLS, while serious, is something we usually manage well proactively. The biggest, most anticipated side effect is myelosuppression.
Myelosuppression, bone marrow suppression.
Exactly. The chemo wipes out the bone marrow's ability to produce blood cells. All blood cells, white cells, red cells, platelets.
And the biggest immediate danger there is?
Neutropenia. A severe drop in neutrophils, which are the main type of white blood cell that fights bacterial infections.
When does that usually happen?
It typically hits hard around day 10 after starting chemo. The neutrophil count plummets, sometimes close to zero.
Leaving the patient completely vulnerable to infection.
Extremely vulnerable. This is often the most dangerous period.
So what do? Put them in a bubble?
Almost. We use strict infection control measures, sometimes called reverse isolation, protecting the patient from the environment.
How does that work?
Healthcare staff wear masks, gowns, gloves. Hand washing is obsessive. Visitors are usually restricted or screened carefully. Sometimes special air filtration rooms are used.
And monitoring.
Constant vigilance. Daily temperature checks are vital. Even a slight fever is treated as a potential emergency.
What happens if they get a fever?
If a patient spikes a fever while neutropenic, we immediately draw blood cultures, urine cultures, maybe a chest x-ray, and start powerful broad-spectrum intravenous antibiotics right away, You can't wait.
Because any infection could become overwhelming fast.
Very quickly. We sometimes use something called GCSF, granulocyte colony stimulating factor, after the chemo is finished.
What does that do?
It's a growth factor, a medication that stimulates the bone marrow to recover and start producing neutrophils faster. It can shorten that period of severe neutropenia.
Okay, so that helps with the white cells. What about the other blood cells? Red cells, platelets?
Right. Anemia low red blood cells and thrombocytopenia low platelets are also expected. This means patients almost always need blood transfusions to manage the anemia symptoms, like fatigue and shortness of breath.
And platelets?
And platelet transfusions to prevent or treat bleeding, because platelets are crucial for clotting. With very low platelets, even minor bumps can cause bruising or nosebleeds or more serious internal bleeding.
So lots of transfusions are just part of the process.
A very standard part of managing 7+3 induction. And we also have to be very careful to avoid invasive procedures if possible to minimize bleeding risk.
Okay, that covers the blood counts. What about other side effects? People always think of nausea, hair loss.
Yes, those happen too. Nausea and vomiting can be significant, but we have much better anti-nausea drugs now. Like the 5-HT3 antagonist ondansetron is a common one, usually given proactively. Hair loss is, unfortunately, almost universal with this regimen.
And what about inside? The mouth and gut?
Mucositis, that's a really tough one. It's inflammation and painful sores that can affect the entire digestive tract from the mouth down.
Ouch. That sounds miserable. How do you manage that?
It requires really rigorous oral care, frequent mouth rinses with saline, sometimes special magic mouthwash concoctions. Antifungal prophylaxis is important too, to prevent thrush. Pain control is key. And if the mucositis is severe or nausea is uncontrolled, patients might not be able to eat or drink enough.
So then what?
Then we rely on nutritional support. Sometimes that means tube feeding, but often it requires TPN, total parenteral nutrition.
Feeding directly into the vein.
Exactly. Providing all the necessary nutrients intravenously until their gut recovers.
It's just incredible the level of support needed.
It really is. And throughout all this, we're constantly monitoring organ function, liver, kidneys, and especially keeping an eye on that cardiac function because of the anthracycline risk we discussed. Regular blood tests, checking fluid balance. It's intensive care, really.
No kidding. Okay, so the patient gets through this incredibly intense period, the 7 days, the 3 days, the recovery. What's the very next big step? How do you know if it actually worked?
Right. After the blood counts start to recover, usually a few weeks after starting chemo, the crucial next step is another bone marrow evaluation.
Back to the biopsy.
Yes.
Yes.
Typically done around day 14 to day 21, though sometimes a bit later depending on count recovery. This is the key checkpoint.
And what are you looking for?
We're looking for blast clearance.
Ah.
Have the leukemia cells, the blasts, been effectively wiped out from the bone marrow? Ideally, we want to see less than 5% blasts and recovery of normal blood cell production.
Okay. What happens if, well, what if it didn't work? If there are still lots of leukemia cells?
That's obviously not the outcome we hope for. If significant residual disease is found, meaning the leukemia is still clearly present, the patient might need to undergo a repeat induction cycle.
Another round of 7+3, or something different.
It could be another round of 7+3 or sometimes a different, perhaps stronger chemotherapy regimen. This is often called reinduction or salvage therapy.
Okay, but what if it does work? If that bone marrow biopsy shows remission?
That's the goal, achieving complete remission or CR. If that happens, it's a huge milestone. But it's not the end of treatment.
Right, because the leukemia could come back.
Exactly. Induction gets you into remission, but the risk of relapse is high if you stop there.
Yeah.
So the next phase is consolidation therapy.
Consolidation, to solidify the remission.
Precisely. To kill off any remaining undetectable leukemia cells and reduce the chance of the cancer returning.
And what does consolidation typically involve?
That depends on several factors, particularly the patient's initial risk stratification based on the leukemia's genetics and other factors, and their age and fitness. Common options include several cycles of high-dose Cytarabine, often called HiDAC, much higher doses than in the 7+3.
Even more intense chemo.
In terms of dose per day, yes, but usually for shorter durations. Or for patients with higher risk AML or those who are suitable candidates, an allogeneic stem cell transplant might be the recommended consolidation.
A transplant from a donor.
Correct. That's a whole other complex procedure, but it offers the best chance of long-term cure for many high-risk patients.
Wow. Okay. This deep dive into 7+3, it's really highlighted how it's just the first step, albeit a massive one, in a much longer journey.
Absolutely is the foundation.
It's truly a cornerstone treatment for AML, isn't it? But it's so clear that it's not just about the drugs. It's this incredibly complex, vigilant, all-encompassing framework of supportive care that makes it even possible.
You've got it exactly right. The supportive care is the treatment in many ways. It allows patients to tolerate the chemotherapy needed to fight the leukemia.
Yeah.
And, what this deep dive really reveals, I think, is the incredible precision involved. That constant, careful balancing act between immense risk and potentially life-saving benefit.
Yeah, absolutely.
And just the remarkable dedication of the entire medical team, doctors, nurses, pharmacists, technicians, everyone involved.
It's truly pushing the boundaries, day by day.
It is. All required to fight a disease as aggressive as AML and give patients the best possible fighting chance.
So maybe the thought to leave everyone with is this. What does this intense look at just one protocol, 7+3, tell us about the sheer complexity, the human resilience, and the constant innovation needed across all of medicine when facing down these really formidable diseases? What does it show us about where we are and maybe where we still need to go?